kind of.
Okay, and why? Why is it? Why do you screen them?
Carrier frequency is about 1 in 12. It's a common disease and cause risk.
Okay, all right. So let's say you send your sickle cell, your hemoglobin electrophoresis comes back that she's a hemoglobin S carrier. How do you discuss that with her at the next visit? How do you have what conversations do you have with her? You look interested. What's your Kate?
Kate, yes. Kate.
Kate.
Kate. Non-English.
Pardon?
Even though I get a lot of education, which is great, especially the UIN ones.
That's all right. You don't know what I get for Jared Martin.
And you look so good. Right.
Maybe not fair. Andrew, you've had a year. You've got a year under your belt. What conversation would you have with someone who you find out is a carrier for sickle cell? Because it must be happening a lot, right? Because you're screening everybody, and 1 in 12 are carriers. So we see 12 new OBs a week, at least, probably, right? Got to have at least one a week.
Yeah. Besides just testing their urine each trimester, I also discuss with them the fact that there's a chance to, obviously the chance for passing that trait on to the child, and ask them if they have any awareness of what their, what the father and baby status is.
What are you looking for in their urine?
They just have a greater incidence.
Trait? People with trait? See, I learned too. Do you? So she says she thinks he said he doesn't have it.
Do we assume that's true?
I don't know. Do we assume that's true?
Okay, assuming that's true, then
Okay.
I tell her, there's a 25% chance of her passing the trait on to her child, which may or may not be of any significance to her, depending on the future.
So she has the trait, and the chance for her child to have trait is
25%.
so if she has the trait.
50.
Right. So she has one normal copy, one changed copy, right? 50-50 that she'll pass it on. Okay. And then if her partner also is a carrier for hemoglobinopathy, 50-50 he'll pass it on. Do you know anything about newborn screening for hemoglobinopathies in Missouri? Anybody know? Right. So screened for in Missouri. Okay. So all newborns, regardless of ethnicity, are screened for sickle cell. And thalassemia.
But is that hemoglobin electrophoresis?
You know what? I honestly don't know how
I
they.
think it's a sickle dance. Because it's done on a spot.
No, it is done on a spot. Honestly, I'm embarrassed to say I don't know exactly how they do it.
Because I may be misinformed.
But they'll be screened.
I thought it was a sickle dance.
Yeah.
Hemoglobin solubility.
I'll get back to you. Dart nose? Is it a? So here's the reason I'm going through this little exercise is basically I want to review sort of how do we decide what we're going to screen for. Okay? So basically there are pretty well-defined criteria that if a disorder meets those criteria, public policy is often written such that we are mandated to offer testing to our patients. And groups of people that are often sort of identified as potential people to be screened are newborns, right? And pregnant women or women considering pregnancy, preconception counseling. So first of all, a disorder has to be serious. Right? So it has to have serious consequences for the well-being and potentially lifespan of the individual who's affected with that disorder. There has to be a good test for screening, a test that has high sensitivity, identifies as close to 100% of people who are affected or carriers in this case, and it also has to have very high specificity. You can't have a bunch of false positives. Okay? If the test is negative, you want to correctly identify those individuals as negative. there has to be a treatment. So that's a part of the equation that goes into determining what will and won't be screened for that is often hard to understand or elucidate. Okay? And in other words, you want to be able to have an impact on the outcome of someone who is identified to be a carrier or to be affected. And from a prenatal standpoint, as you know, there are very few conditions that are amenable to prenatal treatment. And although that is the goal of many people, to be able to identify and treat serious fetal conditions before delivery, gene therapy is not one of them. So for almost virtually all genetic conditions, congenital adrenal hyperplasia, the one exception, where maternal therapy with high-dose steroids can significantly reduce the incidence of genital abnormalities in affected females, we really don't have effective prenatal treatments. So one of the questions then is, why do we target pregnant women or preconception counseling couples for screening for these disorders, things like sickle cell, things like cystic fibrosis? And of course, one of the reasons is to afford couples who are at risk, 25% risk, to have a child with a particular condition, the option, if they're preconception, of pre-implantation genetic diagnosis, going through in vitro, biopsying embryos and only transferring unaffected embryos, or using gamete donors. Could use sperm donation or egg donation, obviously from unrelated screen-negative donors, or adopt, not have children. Once they are pregnant, the options narrow considerably. And at that point, the option really is to undergo prenatal testing with the option of interruption of pregnancy in the event that an affected child is demonstrated, or forego prenatal testing and await testing at birth. But things like sickle cell and cystic fibrosis and a host of other conditions are in fact screened for in the newborn screen. So it sets up, I think, a bit of tension between trying to look at cost effectiveness, for example, of offering screening to pregnant women when, in fact, unless they choose to exercise reproductive options and interruption of pregnancy, there's no benefit to the fetus. And in fact, we've already committed as a society to newborn screening. So those are sort of some background issues that I just wanted to kind of talk about a little bit before going on with the talk. Okay. The other thing to remember is that this testing is optional. All right. And in fact, it is appropriate to obtain an informed consent. When you screen someone for a condition, obviously if they come back screen negative, everybody feels good and happy and relieved and we move on. But if you identify that an individual in fact is a carrier for a genetic disorder, you then set up a cascade of a conversation which involves, first of all, making sure they understand that they're not sick, that there's nothing wrong with being a carrier, which many people don't assume right off the bat. And then having the conversation about the potential for an affected child. You're often talking about a disorder, usually talking about a disorder that they've never even heard of, and you may not even have seen or had direct experience with. These are rare disorders. And the necessity of assessing their partner, who often is uninsured or underinsured. And of course, even a hemoglobin electrophoresis is several $100s. And when you then toss out the fact that the baby will often be screened as a newborn, the family decides to obviate any further testing, waiting newborn screening. But you've then sort of cast somewhat of a shadow over the remainder of the pregnancy while they're waiting for the outcome of their pregnancy and their baby to be tested. So in fact, when you are talking about screening with your patients, I suggest that you actually try to carve out a few minutes to actually talk about the implications of the test that you're offering them and give them the opportunity to decline. I'm going to start off by talking about preconception and prenatal carrier screening for genetic diseases in a particular group of individuals whose origin or ancestry is in Eastern Europe, specifically of Jewish descent or Ashkenazi Jewish individuals. And this is a population that is relatively infrequently encountered here in St. Louis, but is much more prevalent on the East Coast. And it is important that you understand and know sort of what the guidelines are for offering screening. The Ashkenazi Jewish community originated from a relatively small geographical area. And as such, there's something called founder effect, which you may have heard or bring back from your genetics courses in medical school, that mutations that were existing in a small population, which then remained relatively sequestered for many generations, particularly if there's a survival advantage to being a carrier for that disorder, but even if there isn't a survival advantage to be a carrier for that disorder, the frequency of that gene in the heterozygous state increases. And there are a host of autosomal recessive disorders that are more prevalent in individuals of Eastern European or Ashkenazi descent. And in fact, one of those disorders, Tay-Sachs disease, which probably everybody's heard of, really was one of the first conditions, in fact may have been the first condition, that was that screening for carrier status was implemented on a population-wide basis very early, back in the 1970s. And in fact, at that time, there were two very interesting ways that the public health and in fact the Jewish community themselves introduced screening. And one was through, in fact, synagogues. And please correct me if I'm wrong. I'm talking from book learning, not direct knowledge, but in fact, before or sort of around the time of, usually in high school, members of the community would be screened. And marriages within that community were often somewhat arranged, and there was utilization of individuals' carrier status for Tay-Sachs that was taken into consideration in the matchmaking process in order to ideally prevent two carrier individuals from marrying and having that 25% risk for Tay-Sachs. The other place where it was introduced was in the public high school system, and that actually occurred in Montreal, in Quebec. And they targeted high school students to screen for Tay-Sachs, believing that if they identified carrier status for Tay-Sachs prior to beginning their reproductive career, that in fact individuals who were identified to be screen positive would in fact self-select partners subsequently to have children with who were ideally non-carriers. So Tay-Sachs has been routinely offered, Tay-Sachs carrier screening has been routinely offered to individuals of Ashkenazi descent for over 40 years, with the recommendation that all individuals be offered cystic fibrosis screening. Of course, cystic fibrosis, Ashkenazi Jewish individuals are also offered CF screening, and they also, in fact, unlike the Caucasian population, where delta F508 is the main mutation that's seen within the Ashkenazi Jewish population. There are 3 mutations that account for about 97% of the alleles. Delta F508 is one of them, and then there are 2 others. And the third disorder that was added to the Ashkenazi Jewish panel was Canavan disease. But the guidelines were updated. This is from October of 2009, and this table is actually listing some of the more common autosomal recessive disorders that are seen with increased frequency in the Ashkenazi Jewish population. And in 2009, ACOG recommended that 4 of these disorders, Tay-Sachs, Canavan, CF, and another disorder called familial dysautonomia, that those 4 disorders be offered to individuals of Ashkenazi Jewish background for screening. Carrier frequency is around 1 in 30. Yep.
I got a publication from, and I don't know if it's targeted as an obstetrician or just as a woman, and it's either from National Council of Jewish Women or Jewish Federation, but there are 29 on the list now.
Right.
And they have them all listed out, and there were pamphlets that came with it, but I'm not sure why I was targeted, but this is now coming out from
Right.
political organizations as well.
So there's actually a great website that I utilized partly in preparation for this talk. It's called the it's JG. What's the G? Jewish Genetic Disease Group, and they have very good information about these conditions and about the availability of screening. And I'm going to talk about the expanded panels, but I wanted to just make sure that we kind of hit what are you recommended to be offering. Okay. So what ACOG put out 5 years ago was this list of conditions, the top 4 being recommended to be offered, and I'll talk a little bit. I'm going to talk a little bit about what each one of these is, just so you have a little bit of background. And then there were 5 additional conditions that are listed here: Fanconi, Niemann-Pick, mucolipidosis, Bloom, and Gaucher, that they stated that if an individual of Ashkenazi Jewish descent asked about, are there any other conditions that I may be at risk for or could be tested for, that those additional 5 warranted consideration of screening. Okay. Now, in fact, the commercial laboratories are all over this, and you can have carrier screening for any one of these conditions if you check the one box, but most commercial laboratories that are offering genetic screening, in fact, have a package, and the packages vary between the laboratories. Genzymes, I think, has 14 conditions on it, and of course they bundle them together so that you get a much better price. It's actually cheaper to screen for their whole panel than just to screen for the top, than just to screen for CF and Tay-Sachs. It's actually cheaper to do the bundle. It's like paying for a CMP compared to just paying for a sodium and a potassium. You get a deal. So these are the conditions, as I said, that ACOG have recommended that we discuss. Either we discuss upfront or we discuss if the family asks. There we go. So very briefly, Tay-Sachs disease is related to a defect in hexosaminidase A. It's an enzyme defect. It leads to, it's a lysosomal storage disorder, and affected infants are normal at birth, but within the first 3 months of life, usually they deteriorate neurologically. And although death by age 6 is the rule, and many kids die considerably sooner than that, there's no effective treatment. In addition to the Ashkenazi Jewish population, Tay-Sachs should be looked for in individuals of French-Canadian descent. Remember I told you about Montreal, and the Cajun population. We've talked about CF before. Basically, the gene is the CFTR. Most common features are pulmonary and GI complications. It does shorten lifespan with an average life expectancy now of 35. There is treatment, but there is no cure. There is no neurological component or phenotype to CF, unlike most of the other disorders we're going to talk about. Canavan disease, the enzyme is aspartoisolase. An N-acetyl aspartate accumulates in the brain, so these are also children who, again, are usually normal at birth, and for the first few months they achieve milestones. They then deteriorate, lose all milestones somewhere around 6 months of age, with progressive deterioration and death in early childhood. Familial dysautonomia is a very interesting disease. The gene is written for you there. I'm not going to read the whole thing. This disorder actually is manifested as deficiencies in regulation of the autonomic nervous system. So individuals with this disorder have significant swings in blood pressure. They have insensitivity to pain, uncontrolled sweating. They have increased frequency of infection, which I don't really understand why they get that. And this is a pretty significant quality of life issue. Many individuals will also have neurologic deterioration with time, and their life expectancy is 40 years of age. So that's the fourth condition that ACOG has recommended we offer to individuals of Ashkenazi Jewish descent. The next ones are less common. Fanconi anemia is a disorder characterized by increased chromosomal breakage, which leads to an increased risk of cancer. These kids at birth or soon after birth develop anemia, which progresses to pancytopenia. They become transfusion dependent. They may have birth defects that bring them to attention before the hematologic factors. Radial ray limb defects, so involving the radius and thumb, are relatively common. They can have heart defects. They do have developmental delay, and their life expectancy is about 10 years of age. Fanconi anemia is, I'm going to just leave that. Niemann-Pick is another lysosomal storage disease. The enzyme is sphingomyelinase, and sphingomyelin accumulates in the reticuloendothelial system and ganglion cells of the CNS. Similarly, you'll catch the theme here. Onset is usually within the first few months of life. With Niemann-Pick type A, lifespan is very short, 2 to 4 years. And these kids similarly have a very, and families have a significantly, it's a very sad disorder. Mucolipidosis, very similar, except unlike the other disorders that store in the liver and spleen, the features of mucolipidosis are psychomotor retardation, but also severe ophthalmologic abnormalities and blindness. These individuals live into adulthood, but do have significant mental retardation. Bloom syndrome, you may not have heard about. It's another DNA repair disorder, and so they also have an increased frequency of chromosomal breakage and have a significantly increased risk of malignancy over their lifetime. They're small, often small before birth, and don't grow well after birth. They have extreme sun sensitivity and have a lot of pigmentary issues with their skin, particularly on the face. And the last life expectancy is 30 years of age, usually normal neurologically. And Gaucher disease is the last one, and this is one of the more controversial sort of disorders for screening, I think, and one of the most problematic for counseling patients. So the enzyme is glucocerebrosidase, beta-glucosidase, has 2 names. It's also a lysosomal storage disease, so you get an accumulation of glycosylceramide, particularly in the RES system. So these kids will often come to attention because of hepatosplenomegaly. The problem with Gaucher, one of the problems with Gaucher, is that the phenotype is highly variable, even within families. And there is in some individuals, a severe neonatal onset. So I've seen this as a cause of hydrops, prenatal hydrops. And there's also a neurologic component in about 20% of affected individuals with neurologic deterioration. The major issue for counseling is that the genotype-phenotype correlation is not there. Certain mutations are more likely to be associated with neurological symptoms, and others tend to be protective against neurological symptoms. But for any one individual, you can't predict the severity of the disorder. So you can appreciate that this places an even added burden in families when you're trying to get an informed consent about whether this is a disorder that they would want to screen for in their offspring. The other thing is that there is treatment available. It doesn't treat the neurologic form because we still have that great thing called a blood-brain barrier that prohibits getting medications and enzymes where we want them. But in fact, there's extremely effective treatment that can in fact reverse deposition in the RES system in the bones and dramatically improve quality of life for these individuals. So for that reason, I think Gaucher remains problematic as a disorder that sort of fits criteria, at least for preconception prenatal screening. So how do you sort of go through the process? So first of all, we should determine if either member of the couple is of Eastern European Jewish ancestry or has a relative with one of these conditions. As I said, carrier screening for Tay-Sachs, Canavan, CF, and familial dysautonomia should be offered, ideally before conception, again, so that the family have the maximum of a number of options open to them for reproductive choice. ACOG says that individuals of Ashkenazi Jewish descent may inquire about the availability of carrier screening for other disorders, and that patient education materials should be made available to them. And as Dr. Scheiken was saying, that various social activist political groups, as well as, of course, commercial laboratories, have prepared patient information pamphlets that cover and describe all of these disorders so that the family can kind of make some decisions. A special situation is where one member of a couple is Ashkenazi Jewish and the other is not. It's important before embarking on screening that even if you are not of Ashkenazi Jewish descent, you still could be a carrier for one of these very rare diseases, but the carrier frequency, of course, is going to be less. And in fact, many of these diseases are extremely rare, and they're so rare, particularly in the non-Ashkenazi population, that we don't know the true incidence of the disorder in the non-Ashkenazi population. So because of that, and you can certainly test the Ashkenazi Jewish, you should test the Ashkenazi Jewish individual first if the family wants screening. But if you identify that they're a carrier for a particular condition, cystic fibrosis being the one exception to that rule, we really don't know what the sensitivity of mutation analysis is in the non-Ashkenazi Jewish population, because you're screening for known mutations, and those are the known mutations that are very common in a relatively small population of people. So just like screening for cystic fibrosis, right, it's less sensitive in individuals of Asian or African American background. It's the same when you're talking about the Ashkenazi Jewish panel. You may identify 95% of carriers if you're testing an Ashkenazi Jewish population. We don't know what percentage of carriers you're identifying if you test a non-Ashkenazi Jewish individual. So in fact, you may not be significantly reducing their risk. So some couples will still elect to proceed with screening the Ashkenazi Jewish member first. Some couples will choose not to do that screening. The one exception is Tay-Sachs. There is, in fact, prior to identification of the gene and mutation analysis, enzyme assays for HexA were possible and, in fact, identify about 97 to 98% of carriers. You can't use enzyme testing in pregnant women, but you can use it in men. So the one exception for offering carrier screening to a non-Ashkenazi Jewish partner would be Tay-Sachs and you would do an enzyme assay, not the DNA testing. Okay. And the last part of this is just talking about what do you do when an individual is found to be a carrier. And I think this is something else we tend to forget about. But we do have a responsibility to let them know that if they are carriers, they inherited that almost certainly from one of their parents. We don't know which, but means that other family members are at increased risk to be carriers. Right? And we do not have an obligation. In fact, we, based on confidentiality, we cannot contact family members to offer them testing or to let them know about the fact that, by the way, your daughter's a carrier for sickle cell. But we do have a responsibility to educate them about the fact that this does potentially have implications for other family members, and they may wish to educate them. And it's often helpful. I'll go to March of Dimes or one of the other websites and just print off an a patient education piece to give them so that they have something to talk from with their family. So it's important to remember that we think about the family as geneticists. I'm going to talk just in the last few minutes about two conditions that currently are not standard of care to offer for screening, but that may or may not change in the next several years, so it's important that you're aware of them, okay, and aware of the controversy that exists about screening for these two conditions. And I'm talking about Fragile X and SMA. So Fragile X we've talked about. It's a disorder that's caused by expansion of a trinucleotide repeat, CGG, in the 5' untranslated region of the FMR1 gene located on the X chromosome on the long arm. As you may remember, we characterize an individual's status with respect to Fragile X based on the number of repeats that they have. Individuals with 6 to 44 are considered normal, and those repeat lengths are inherited in stable fashion between parents and children. Repeat numbers between 45 and 54 is called the gray zone. There's always a gray zone where, although expansion is extremely unusual, it has been rarely reported. Individuals with repeats between 55 and 199 are called pre-mutation carriers. So these are expansions that are prone to expand when passed from mother to child. Fathers pass their alleles in a stable way, right? So dads, however many repeats a dad has on his X chromosome, he's going to pass that in a stable manner to his daughter, right? A woman who has an expansion between 55 and 199 is at risk, if she passes that allele to her children, she is at risk for that allele to expand, and it may expand from 55 to 99, or it may expand from 55 to over 200. Over 200 is called a full mutation, and it is expected that an individual who inherits 200 or more repeats will have some phenotype, specifically developmental delay, often with autistic-like features. But there's great variability, particularly in girls. This is an X-linked disorder that is a little bit unusual in that women who are, quote, carriers of a full mutation, at least half of them will have some features of the disorder. The other way in which this disorder is a little bit unusual is that we generally counsel families that people who are carriers, and we consider people who have a pre-mutation a carrier for Fragile X, we usually counsel them that carriers are healthy, that there are no health consequences to them by being carriers. We now know that for Fragile X, that's not the case. About 20% of women who are carriers of a pre-mutation allele will undergo premature ovarian failure, so cessation of ovarian function before the age of 40. And as such, it's recommended that women who are experiencing or diagnosed with POF be offered screening for Fragile X. There's also a disorder called Fragile X tremor ataxia syndrome, which often onsets around the age of 50. And there's progressive development of ataxia and tremor, personality changes, and ultimately cognitive decline. So identifying someone as a pre-mutation carrier, we now know has significantly more implications than just reproductive implications. Right? So important that you know that.
What about males? Does it affect
the tremor ataxia? Yes. They don't get premature ovarian failure, though. The incidence of Fragile X is between 1 in 4,000 and 1 in 6,000. It's actually the most common inherited cause of mental retardation. Carrier or premutation screening in populations of women have yielded variable results. In Israel, there was one population-based carrier screening study that identified about 1 in 160 women to have a premutation allele size. A Canadian screening study suggested the incidence was about 1 in 550. As a ballpark, 1 in 300 is the number that's generally utilized in most sort of education and review material about frequency of premutation carriers. So the question is, of course, does Fragile X fit the criteria for something that would be offered as on a population basis? And we know that it's serious. Okay. Basically, it places a significant burden on the affected individual as well as their families. Is there a good test? Yes, there's a good test. Using a combination of PCR and Southern, we can identify the number of repeats that an individual has within 1 to 2 copy numbers. Is there treatment available? Specifically, treatment, no. There is a lot of active research trying to identify potential treatments for this disorder, but there's currently nothing that is effective. There's a lot of also research being done looking at how to assist these individuals to maximize their potential developmentally and in terms of just general sort of coping skills within their family and within their community, but there's no cure. So again, this is a condition that would potentially, if offered to pregnant women, would be utilized for reproductive decision making. Yeah.
Mouse models now, they're actually showing the treatment. And what you're thinking is it's sort of like those of us who remember records. You have a scratch in the record, repeats itself and repeats itself and repeats itself. And so in the mechanism and machinery of DNA, it repeats itself and repeats itself and repeats itself, and that's what causes the mutation on the molecular level. What they're trying to do is sort of smooth over and bypass all these repeats, so you sort of jump over it. And there's actually been, so they did studies with mice, and they're showing there's actually been a good tree in the brain is actually starting to synapse. So that's let me hear your toys.
The hope, right? The hope.
So based on how many copies, do we know what the rate of it being passed on? Like having an
Yes.
affected offspring?
Yes, and I didn't put that in the talk, but yes, there are tables that you utilize when you're counseling your family. And I don't remember off the top of my head all the breakpoints, but for example, if you're in that sort of, I know just from a recent patient, if you're in sort of the 80 to 90 repeat, your risk of expansion is about 75%. Expansion to a full mutation. And then it's even more complicated than that, because what is believed to the mechanism by which what happens is the gene becomes deactivated. So you lack the FMR1 protein based on methylation of the CGG repeats, which then inactivates or silences the gene. And there's in addition to your repeat size, the degree of methylation is also often variable within individuals. So prediction of phenotype is extremely difficult for any one repeat length, trying to determine how severe it'll be. So this was a position paper that came out in 2008, I think. Was it 11? From in Genetics in Medicine. And basically it was a paper looking at arguments both in favor and against screening for Fragile X. And the arguments in favor are that, again, as I said, it's severe. There is a relatively high incidence in the general population, 1 in 300 women being carriers. There is a significant impact of the condition on the individual, family, and society, and accurate testing is available. The arguments against screening are that the severity of the condition is variable, and it's very true, particularly among girls. So counseling a family who have prenatal prediction of an affected female is particularly difficult. The pattern of inheritance is complex. As I said, there is a variable risk of expansion. And there's also a phenomenon called a normal transmitting male. As I said, there are males who inherit a premutation from their mother, and they will pass a premutation to their daughters. So it's a condition that we typically think about as being passed through the women in the family, but there are males who may transmit the premutation to their daughters and not be, in other words, normal males passing it to their daughters. And the other argument against screening, in fact, are the health risks associated with being a premutation carrier. We have no way at the current time to prevent the development of the ataxia tremor syndrome. So in fact, it's important before you screen someone to let them know that if in fact they are a premutation carrier, you are telling them that they are increased risk for early onset of neurologic complications later in life.
So a question about the normal male carrier. So
Mhm.
is the premutation inherited by a female of paternal origin behave the same way in that woman, or is
Yes.
it that, okay, so it is still inherited as a stable premutation?
So it's inherited as a stable premutation from her father, but it then becomes vulnerable to expansion when she passes it to her offspring.
Got it.
Yep. Yep. So pedigree analysis is very tricky. Yep.
Dr. Martin, I forgot the exact term from the Georgia Med School, but do you see like expansion of those repeats in subsequent generations? Like if the mom has it, or her daughters have more repeats, followed by more repeats of their siblings?
So, right. So once you reach that threshold of 55 repeats, there tends to be expansion when passed from a mother to a child, but it is not 100%. I don't believe this. There are some trinucleotide repeat disorders where the allele size has shrunk from parent to child, but Fragile X, I don't believe there are well-documented cases of shrinkage of allele size. Only expansion, but it may be inherited in a stable fashion. Yeah, and when inherited from a dad, it's inherited in a stable fashion. Yeah. So both the NSGC, National Society of Genetic Counselors, and the Society of OBGYN Canada have issued policy statements related to Fragile X screening. And what these two bodies said was that they recommend that screening for Fragile X be offered, again the key offer, to individuals with obviously with a family history of Fragile X, or with a personal or family history of unspecified mental retardation, autism, ataxia, or premature failure. So when we're doing genetic counseling and we look at a pedigree, basically we look at it's not unusual for there to be a family history of somebody with developmental delay in the family. And so we basically do a pedigree analysis to look at if that was Fragile X, what is the likelihood that this particular individual is a carrier. And unless we can absolutely rule out the risk for inheritance, we typically will offer a karyotype, looking for structural chromosome rearrangements, as well as Fragile X carrier screening. Yep.
So when you elicit this history, it could be vague. Do you recommend doing formal genetic counseling every time or ordering screening?
I think it's a comfort level in terms of how comfortable you feel about it, about your and also how much time you have. Certainly a first or second degree relative. So, for example, if you had an aunt or an uncle or a brother, sister, the risk is high enough certainly to warrant offering screening. But the counseling beforehand, of course, assumes you have to go into the issue of we don't know what the diagnosis is. There are a lot of conditions that can cause mental retardation. There are some we can test for, and one of them is something called Fragile X, and the other is looking for a rearrangement of genetic material. If you have normal testing for these two things, we've ruled them out, but it's entirely possible there's something else in your family history that we can't test for and we don't know. So I think as long as you can have that conversation, I think I would feel comfortable offering a karyotype and Fragile X carrier screening. But we're always happy to see the patient. Yeah. The last condition I want to talk about is SMA. And it's also type 1, which is the most severe form of spinal muscular atrophy, is called Werdnig-Hoffmann, and so you may know it by that name. And the SMAs are a group of recessive disorders, and the underlying pathology is degeneration of anterior horn cells. So it leads to symmetrical muscle weakness, atrophy and early death. It is actually the second most common lethal AR disorder in Caucasians. It occurs in about 1 in 10,000 live births. And it is characterized, 4 subtypes are characterized based on the age of onset, the maximum muscular activity that the affected individual achieves, and how long they survive. And the disorder we are most focused on is the type 1, which is the severe infantile form. also called Wernig-Hoffman. There are 3 other subtypes that tend to present a little later with prolonged survival. And of course, these subgroups were determined or were described before anyone knew what the underlying genetic mechanism was. It turns out, in fact, that all 4 subtypes represent mutations or secondary to mutations in a gene called SMN1, survival motor neuron gene 1. This is actually, there are 2 genes closely located on chromosome 5. They're called SMN1 and SMN2. The sequence of SMN1 and 2 differ by a single nucleotide in exon 7. And the difference leads to decreased transcription and production of SMN protein in SMN2. So SMN1 produces normal amounts of the SMN protein. SMN2, because of that single nucleotide substitution in exon 7, produces significantly less amounts of SMN protein. Individuals with SMA lack both copies of exon 7 in SMN1. So if you look at the underlying genetic mechanism with Wernig-Hoffman, most affected individuals have 2 copies of SMN2, but have no normally functioning SMN1. And basically, the severity of the phenotype correlates not only with the lack of SMN1, but also the number of copies of SMN2 that you have. That mutation in exon 7 in SMN2 does not completely eliminate protein transcription. So the more copies of SMN2 that you have, you are relatively protected, and it prolongs the length of time of normal life. It's thought that many of the mutations arise from unequal crossing over during meiosis. And again, because SMN1 and SMN2 are so similar in sequence, there's potential for mispairing during meiosis. If you think back to alpha thalassemia and the alpha thalassemia genes, right, we have 4 of them, 2 on each chromosome, and if you get if they match up incorrectly, you end up with one product with 3 copies of the alpha gene and 1 copy of the alpha gene on the other product. Similar for SMN1, SMN2. But there are basically 2 types of mutations that lead to loss of function. You can either have a whole deletion, or you can have this point mutation in exon 7. The carrier frequency, so looking at how many individuals are an SMN1 carrier, is between 1 in 40 and 1 in 60. It does vary a little bit based on ethnicity, so it's more common in the Caucasian population, less common in African American and Hispanic populations. The most common way that someone is a carrier is to have a deletion of one of their SMN1 genes. The most common genotype in Caucasians is to have 2 copies of the SMN1 gene. So most of us are normal, non-carrier with respect to our SMN1. African Americans actually have a high frequency of alleles with multiple copies of SMN1, which probably explains the decreased incidence of the disease in that particular population. So SMA is currently in a genetic detente. This is a paper issued by the Practice Guidelines Committee for the American College of Medical Genetics in 2008. And Dr. Pryor recommended that, for these reasons, that carrier screening for spinal muscular atrophy should be offered to all pregnant women and couples considering becoming pregnant. However, and this is a little unclear, Point 2, formal genetic counseling services must be made available to anyone requesting this testing. So because the genetic abnormality with SMA is so complex, and because carrier testing is very good for complete deletions of SMN1, but not as good for the exon 7 base pair substitution, the interpretation of results are particularly challenging. So what he recommended is that SMA carrier screening should be offered, but should be offered in the context of formal genetic counseling. I don't think we have enough genetic counselors in the whole world to provide genetic counseling for SMA to all women, to all pregnant women. And then, of course, point 3, all identified carriers should be referred for follow-up genetic counseling for a discussion of risk to fetus or future pregnancy. So you get genetic counseling, then you get follow-up genetic counseling. So this came out in November of 2008, and point 4 highlights sort of what I was just saying, that if the screening test is negative, meaning if both members of the couple, one or both, have the presence of SMN1, have SMN1, you've significantly reduced the likelihood, but you only have about a 90% detection rate because of the possibility of single of undetected mutation. So it's like CF in that regard. But the other problem is that based on the number of SMN2 alleles you have, even if you are missing both your SMN1 alleles, you may not, your offspring may not have the neonatal infantile form because of the modulating effect of SMN2. So he points that out and how problematic and difficult that is to talk to families about. So ACOG in May of 2009, I think, did a hurry up and response. And basically, they went through exactly the same information about SMA, how it's inherited, the carrier frequency, and came right out and said preconception, prenatal screening for SMA is not recommended in the general population at this time. If there's a family history, or if the family requests information about SMA, that they should have genetic counseling. So they actually said that this is a disorder where if somebody comes to you and says, I was reading in a magazine about SMA, Wertnick-Hoffman, that this is a couple that they suggest you refer for genetic counseling so that the family can have accurate and complete pre-test testing. So this remains in limbo. So you have ACMG basically saying that they think that everybody should be offered SMA screening, and you have ACOG coming out and saying that they don't feel at this time that it's appropriate to offer SMA screening. We've taken the position here that we do not offer SMA screening unless a family specifically asks for SMA screening, and that may be in the future. Lastly, last 2 minutes, unknown to the rest of the world, members of the scientific community have been making their own babies to order for quite some time now. This gets to the issue of, how much testing do you want to have? And so I wanted to highlight this thing called Counsel, C-O-U-N-S-Y-L. And some of you may have seen this name in a genetic counseling summary, but fortunately in Missouri we're still relatively protected. So Counsel offer for most insured patients pay no more than $99. And for $99 they will test you for carrier status for 104 genetic disorders. They say that they've chosen their list of diseases because they are, quote, actionable. They don't define what actionable is. And they point out that some of the diseases they screen for cause birth defects and shorten lifespan. And they say the good news is that early knowledge of your risks allows you to plan for a healthy family. So families or couples who come in saying they want to be tested for everything have the option to have one of these expanded carrier screening panels. The sensitivity for each disease is different, so they don't detect the same percentage of carriers for each disease. And as I said, there are a total of 104 disorders, so in fact getting true informed consent about each disorder, do you want to be tested for this, don't you want to be tested for this, is essentially impossible. Two of the conditions that are on their list that I thought were interesting, one was achromatopsia, which is complete color blindness. And although it does not affect lifespan, the person will have poor eyesight, particularly in bright light. The disease is not progressive and will not lead to blindness. But this is something that is tested for. They also test for MTHFR. And so in an era where we're doing everything possible to stop people ordering MTHFR testing, this laboratory has decided that that should be in their panel of carrier tests. And their information it's very interestingly worded, but ultimately they do say that it really doesn't matter if you're an MTHFR carrier, but nonetheless they do include it in their carrier panel. So these commercial products are out there. They're relatively inexpensive. And if you do have a family that is basically requesting testing for everything, I suggest you refer them for genetic counseling, and the counselors will be happy to talk with them about some of their expanded options. And that's it. Thank you for your attention. Yes?
Very good. So what do you tell a patient that wants to be screened for everything?
So what I tell them is, I take a step back. So I've taken a family history. I know what her age is, and I know what her ethnicity is. So I talk to her about those things, and then I say, so 3% of all babies are born with some type of birth defect or learning problem. We identify about half of those prenatally, even in the event that you have every test that's available to you. And if you want to be tested for everything that's available, you can have karyotype, you could have NIPT, you could have an amniocentesis and a microarray. You could have the expanded carrier panel and test for 104 different conditions. But you're still looking at least a 1% chance that you will have a child with some type of birth defect or learning problem. And if you wait until that child reaches the age of 10, it's probably up to 7 to 10%. So if you understand the limitations of what I'm offering you, this is what's available to you. But recognize that there's no guarantee. And what I'll often say is, what I often tell people is that if you really can accept no risk in having children, you should adopt a well-adjusted Harvard graduate if you can find one.
Why Harvard?
Well-adjusted Mizzou graduate. That might be less hard to find. I don't know. Yeah. And it is very important, and that's the other reason why I suggest if you have a family that are looking for sort of everything, that you refer them for genetic counseling. Just because we can take the time to go through that whole scenario and make sure that they understand. But, we got a referral this week from SIU. Dad's a doc and asking for, she's 37. She's 13 weeks, and she had a negative NIPT 2 weeks ago, and they're wanting CVS and a microarray. And we were sort of talking about how the counselors and I were kind of talking about, okay, well, how do we triage this, and who do we talk to, and the main problem with microarray, right, is you're looking for very small deletions, duplications, and even in fetuses with structural anomalies, you do get a pickup rate of about 5 to 7% with a microarray above your standard karyotype, that there's about a 5% pickup of additional deletions, duplications that you don't see with standard karyotype. but there's almost an equivalent number of deletions, duplications of unknown clinical significance that have not been associated with underlying syndromes or specific abnormalities, which are very difficult to counsel patients about, but less difficult when you did the test because you saw a heart defect or a cleft lip or IUGR or something else. Okay, you're thinking more that this may be in fact clinically significant for this individual. But when you find these copy number variants of uncertain significance in an apparently normal fetus, of course you test the parents, and if one of the parents has it, you feel more comfortable. But we also know that there's variability within families in the same genetic disease. So in fact, a parent could have a mild manifestation of something that in fact is much more severe in their offspring. So the whole issue of testing normal appearing fetuses with microarray, I think is very problematic. It turns out in this family that there's some debate between the husband and wife about just how much testing they should be having. And when we contacted her directly, she said, "I'm not having this test." So we're not seeing her. And of course, that's the other thing. When you get one of these requests, I think it's important to actually understand what is behind the request for the test. When you have a couple who are requesting being tested for everything, what are they concerned about? And really sort of try to explore with them what type of information they're really looking for so that they know whether or not that's even information you can really ever give them. I'm going to stop. Any other questions? You're welcome.
Let me read this. Give me a second.
Yeah, I screwed it. Sorry.
No.
Hey, Kim, I had a phone call from folks on the east